And without any further ado, let me go ahead and introduce today's speaker. Today we have Dr. Khurram Nasir. So Khurram is currently the Chief of the Cardiovascular Disease Prevention and Wellness Service at Houston Methodist, and he's the co-director for the Center of Outcomes Research at Houston Methodist. So Khurram, I think, is a very well-known individual, and we're very fortunate to have him join us here just within the last few months. Khurram started his medical training with his MD from Pakistan, and then came to the US where he did a master's degree in public health at Johns Hopkins, did internal medicine at Boston Medical Center and cardiology fellowship at Yale. He went on to do additional training, NIH T32 fellowship in cardiac imaging at Massachusetts General Hospital. And Khurram has also earned a master's degree in health economics from the London School of Economics. So I think, as you'll see, he is not only a very scholarly individual, but a very charismatic personality as well. So Khurram, I could go on and on. I mean, he has numerous publications. I think it's the last count is over 550. So I think his CV is going to use up a lot of pages of paper. But I think we're very, very proud to have Khurram here. And I think instead of me talking, I want to turn the floor over to Khurram. And he's going to really talk to us about a field that he has been involved with, I think, from really the ground stages, which is the whole journey of coronary artery calcium scoring. And he's going to tell us how this tool has gone from a screening test to really a decision-making and patient management tool. Khurram, welcome.
Dipan, thanks for a very flattering introduction. And as early this morning, as I was putting my slides together, I just was thinking, how do I broach this topic? And the good thing is I'm among friends here, so I can share my own dilemmas that had haunted me forever for a while, as well as had shaped and evolved my thinkings. So the two things that have really stuck with me for the last 20 years. The first one was when I entered into medical school, there was a huge, I wouldn't say pressure, but a pride to be certain. Know your diagnosis, know your prognosis, know your treatment options. The more certain you are, more expert you would be considered. Now, I understand that for us doctors, uncertainty is hard. Nobody wants to give a murky response. I want to have an absolute pronouncement of what the issue is and how do I need to treat. However, the more educated I got, and humbly I realized from my mentor, Dr. Harlan Cromhus, that the biggest secret in medicine that's been hidden from us, that often evidence is inconclusive. Now, that was one. The other one, when I came to US, I figured it out that trade-offs in healthcare, like anything else, came up with the sinister connotations. We are in the business of rule of rescue. We want to treat everyone. We want to save everyone. But if you want to prevent heart attacks in everyone or reduce the risk of an MI presenting with chest pain in the ED, you need to do a lot. That will mean a lot of waste. And if you want to save some, you're going to miss some. So now in 2020, we are at a critical junction of medicine. I think so the discussion has gone more beyond efficacy to value. And if we have to increase the effectiveness and depth in how we provide and change healthcare delivery, I think so we need to embrace these two concepts. And this is really the story of calcium scoring over the past many years. Many of you who would have been at American Heart Association almost 15 months ago or saw these headlines that American Heart Association boosting, making room, and finding a larger role for calcium testing. Now, for majority, I think so this was inevitable. What's the big deal about it? But as an avid student of medical history and witnessing some of these changes, I can tell you that it wasn't easy. So the story of calcium testing really starts in 1990 when my mentor, later a colleague and now a great family friend, Arthur Eggleston, a guy with Midas touch, I would say, who's also created the South Beach diet, made him much more famous than just the Egerton score, came up with this tool that would give us the peek into the coronary arteries for the first time and pick up calcifications as a marker of presence and burden of the disease, something that has eluded us for years. And of course, it's a rapid CT, doesn't require contrast, 3 to 5 minutes, low radiation. And although now we can boost, it's inexpensive and widely accessible. In 1990, it was done by a special CT, electron beam CT tomography. That was its only used, sold by Imatron, that was later bought by GE, limited access. So now you would think in 1990, and that's exactly what it was, this is a new innovation into finding non-invasive coronary artery disease for the first time. The red carpet was rolled out. Actually not. So just a year before, it was almost 30 after last 2018 accepting the calcium testing role, AHA actually rejected their first abstract when they wanted to present this data. So, hindsight's 2020. So you can see calcium testing didn't come off of a great start. So what exactly is calcium score? We had no clue in early 1990, and the first half was really trying to figure it out. And a lot of work was led by a friend, colleague, Dr. John Rumberger, who was at that time at Mayo Clinic, has been an expert in this space, but mostly using this technique to identify the cardiac function. And they started looking at autopsy studies and humans and all this stuff. And 5 things really came out during the first half of 1990. It's a specific measure for atherosclerosis. If you see calcium in the coronaries, it is athero. However, it doesn't represent the entire burden. It's only about 20%. And we started getting a sense, yeah, it's associated with risk factors, age, cholesterol, diabetes, hypertension, and people who progressed on their invasive angiography tend to have a higher calcium, and somehow they highly correlated with obstructive coronary artery disease. So this was really the first half of the 1990s. In the late 90s, now, of course, we have a hammer and you have to search for the nails. Where exactly would you use the calcium testing? Obviously, what they found out that, if you don't have calcium scores in your coronaries, the likelihood that you're not going to have obstructive disease. And actually, this paper by John Rumberger showed that there was almost virtually no risk of triple vessel disease or left main. In essence, ischemia 0.1. This was really in 1999. If you don't have atherosclerosis, you're not going to have left main and triple vessel disease. Our own Dr. John Memarian, working with colleagues with Paula Raji, showed that you can actually identify people who are coming with acute MI. Most of them tend to have calcifications. And actually, if you follow some of these individuals, they are pretty high risk for developing that. Not only that, you can detect people with silent ischemia. With a calcium score greater than 400, almost 50% of those individuals, at least in the late 90s, were shown to have silent inducible ischemia. And finally, if you use this algorithm, calcification, this test, it actually may be a cost-effective approach as a diagnosis of coronary artery disease and downstream management. But mostly, this was a focus around those with symptoms and people who are at risk for coronary artery disease. And in 2000, the first guidelines, ACC Expert Consensus, came on the verdict on the calcium score. And of course, our own Dr. William Winters was a part of that. And although everyone acknowledged this is a great test in ruling out disease and identifying those at a higher risk, it has the same diagnostic performance as other tests such as stress test, ETT, stress echo. However, the issue is that it's not specific enough. A lot of people with calcium and a high calcium, when they go for the cath, they tend not to have an obstructive disease. As a result, the role of calcium testing in this condition was rejected. So 10 years after the first calcium testing was shown to identify atherosclerosis, we still didn't have any role by 2000. Parallelly, in 2000, what we started seeing is there was a rollout of statins in primary prevention. So WASCOPS in 1994, FCAP, TAXCAP in 1998. And in 2000, the guidelines came together because statins were expensive. We didn't have an idea about their long-term safety, long-term outcomes, so we have to limit it to the primary prevention for the first time. About those individuals who had a 10-year risk greater than 20% were candidate. If you were 10 years of intermediate, 10 to 20, if your LDL is pretty high. So now, this was the time after coming to US, doing my MPH, I said, well, what about, I started toying around with this idea about atherosclerosis in the corneas and looking into the carrier pathway and calcium research. Now, it was an issue. It was almost not accepted by the mainstream cardiology. As a result, what we found that there was tons of efforts, entrepreneurial, direct marketing to the patients, and was thought about as a mean of identifying patients who would eventually end up into the cath lab. So it developed a pretty bad name. The NIH wasn't interested. There wasn't any pathophysiological basis of calcification that could explain the progression of the disease. Not much funding in this space. And asking a lot of my mentors, it was like, maybe this is not the right track, and we need to take a step back, move back. But by that time, I was having second thoughts. We also were seeing a new turn that the helical CT scans were catching up. The temporal resolution, the spatial resolution, and we started thinking, well, there may be an opportunity of widespread utilization considering that we are moving away from the EBCT, and way superior diagnostic, early risk detection and diagnostic ability of calcium score as compared to traditional modalities was definitely very attractive at that point. So sometimes few things really stick to your mind. And in 2004, when I started my internal medicine residency, I saw a patient in the clinic, followed the guidelines, didn't meet criteria for statin, 3 months later, had a heart attack. And that really stuck to me, that what else could I have done? And I started looking back into literature. A year back, actually a great paper was published by colleagues at University of Virginia, very simple study. They took about 200 patients who presented with acute MI. So how would the guidelines classify them? So think about it. You see these patients in your clinic a day before, and 72% of those, 3/4 of them, you would classify them as low risk. 80% would not meet criteria for statin. That potentially doesn't mean that statin is going to reduce the risk in everyone, but at least they would have been a candidate. And you would say, you're low risk, we are not going to do anything. And for me, if we think that subclinical atherosclerosis is really the true precursor, so why not we focus where the money is? And as a result, that year, I tried to replicate this paper and say, well, what about individuals who would have the highest amount of atherosclerosis in their coronaries before presenting with their first MI? How would the guidelines classify them? And exactly the same way, almost 3/4 of those individuals, especially in the young group, would not meet criteria for statin in spite of the fact of having the highest burden of atherosclerosis in 2005. And as a result, sheepishly, we said, well, I understand that the current decision to initiate drug right now is based on risk factor alone, but couldn't we have a more accurate, more focused approach and target those with extensive subclinical atherosclerosis? Not any atherosclerosis, let's just focus with the subclinical atherosclerosis. However, the main issue at that time was there wasn't any prospective data that would identify that using calcium score as a screening tool would identify those above and beyond what we do in our regular practice. However, we didn't have to wait too long. Multi-ethnic study in atherosclerosis, where I've been fortunate to participate with a lot of colleagues out there in US, and a sister study, Heinz-Nixdorf recall in Germany, was initiated in 2000. And the major result came out in 2009 that showed that higher the calcium score, above and beyond traditional risk factors, you would be at a 9 to 16-fold higher risk of having an event. Now, mind you, to put things into comparison, diabetes, which we used to think about CAD equivalent, is about 2 to 3-fold higher risk. Now, there were other competing factors, and it said that only calcium testing is able to distinguish the group who would have an event versus not above and beyond traditional risk factors. Now, compare that to high sensitivity C-reactive protein, which we learned a lot in last week, that was unable to do that. And not only that, it reclassified individuals into groups where you can actually change the management, especially 1/5 if you are in the intermediate risk range. Now, to put things into perspective, CRP would only reclassify 6% individuals. So this was a debate that we had with Dr. Paul Ritker, and that was the time that the next guidelines were coming. And to our pleasure, and the 2010 guidelines came very strongly in favor and say, now we have enough data in selected intermediate, that means 10-year risk of 10 to 20%, you can refine risk prediction by screening those for calcium scoring and identify that they will benefit from very aggressive lipid lowering, AKA statin. However, just a few years back, we also showed that a lot of individuals who were low risk, at that time the low risk criteria was about 10%, and especially if you had a family history, in a retrospective study where we published in 2004 in Circulation and confirmed that in MESA in 2007, that they would have a 2 to 3-fold higher risk of having advanced atherosclerosis and potentially would benefit. And actually, the same year, the ACC appropriate use criteria guideline agreed with these findings and saying, well, in a specific subset of low-risk patients who have a family history, you can use calcium testing to identify who should benefit. Now, 2010, this was kind of the end of my first inning in this space. We are all pretty excited, and where the direction's moving, we all thought, and naively so, that the next guidelines are going to strongly endorse this precision-based approach of detecting disease and treating rather than making guesstimations. However, we ignored some of the parallel efforts that were happening. Now we had long-term safety data on statins. Actually, statins showed to work also in lower risk groups. For example, the Jupiter trial. Statins were becoming generic. They were safe. And the guidelines, the prior guidelines, were heavily criticized for being too narrow in identifying those who would benefit from statins. So in 2013, based on all this, and trying to overcome their original sin, they broadened the category of individuals who would meet criteria for statin, especially in the primary prevention setting. And as a result, they said, well, why do we need calcium testing? So downgraded the calcium testing recommendation for a 2A to a 2B. Now, this was a tumultuous time. We're just trying to figure it out what to do. And you can know that things aren't looking good for calcium testing when ACC comes out, coronary artery calcium score or no more. And Philip Greenland, one of the most wonderful, thoughtful leader in this space, and rightly so, he came and said, look, if you're going to have a recommendation based on traditional risk factors that said anybody with a risk score of greater than 7.5, which is, by the way, almost 1/2, should be treated with a statin, why would you need any additional risk marker, including calcium? What's the point? What are we going to do with it? So what we started to think, and I say, we are headed in the right direction in 2014, but there is a risk for miscalculation. And the reason is there is no such thing as too much of a good thing. We have to go back again. There are going to be trade-offs. And we have to be mindful of those trade-offs. So in my view, the first trade-off was the first ATP guideline in late 90s identified 10 million people with statin candidates. The next guideline, 25. Now, with the stroke of a decision with this guidelines, now there were about 50 million individuals plus, more than 1 in 2 adult population that eventually could be a candidate for statin. Now, if you're from New York area, I can tell you the Staten Islands really was getting crowded out there. And people were finding, can we build walls or find ways around that? But I think we could do something much better. Now, the entry criteria into the statin club, how does that work? So when we looked into that and specifically identified those who would be candidates, your actual observed risk was almost half than predicted. So A, we have asked everyone to join the club. Secondly, people who didn't need to be in the club, almost half of them were getting in. And one of the few things that Paul Ritker and I agree on, that systematic overestimation of a risk is a significant concern because it's going to lead to overprescription of statin therapy in groups when actual scores are much lower than predicted. Now, but the biggest thing that the guidelines and us physicians were forgetting was about our main stakeholders. What about the patients? What do they want? So a great study published in 2014 actually surveyed patients, and when you ask them, and this is part and parcel of our clinical experience, almost 2/3 of them were averse of taking a long-term medication unless they're at a high risk and substantial benefit. And when you ask them, almost 20% were willing to pay $1,000 out of pocket if you can tell them they're at low risk and they don't need to commit to a long-term pill. So this was the landscape. So many people meeting criteria for statin, the criteria that allows you to be a candidate overestimates, and majority of our main stakeholders don't want to be on a long-term pill. So what do? Now, as all of these things are happening, I'm watching it as a bystander, and I was asked to write this editorial, and I wanted to be more thoughtful. I guess this was a year I turned 40, had some gray strands. I was even challenging my own notions and my own beliefs at that time and say, in 2015, when a substantial proportion of adults are already statin candidates, then I agree that this whole notion we need to screen is becoming less compelling. Who are we trying to find? The fourth person? Almost 3 out of 4 individuals are already statin candidates. And that's where I thought based that, our stakeholders, including the patients, are actually going to place a higher value for information to de-risk so that at an individual level, you can allow informed choices and resource allocation at the population level. Now, this was a novel concept, I think so, out of the box at that time. We've never done testing to de-risk. Most of the time, you do a test, identify risk, treat. That has been the concept. And actually, I got some very angry emails and phone calls from my colleagues and saying, I'm trying to herd the calcium story. Would I mean that we don't need calcium screening? And this is madness. But there was a rationale behind that madness. My thing was, okay, fine, but what about if we reverse the role of calcium testing? Can we use this to identify those who may not benefit from preventive therapy? And the reason why I thought this was important, and if you look at the trajectory of where we're going, I feared in the next 5 years, with breakfast, we will be serving statins. Statins are effective, they're cheap, they work. But the question is, do we need everyone to take 365 pills a year if they don't need it? But again, this wasn't just a hypothesis. Actually, we have thought about it a few years back. 6 years back, when I was wrapping up my internal medicine residency with 2 other residents, Michael Blaha, who was a second-year resident at Hopkins, and Amar Sarwar, a radiology resident at Harvard. We came up with this idea, well, everyone's looking at calcium risk. What happens? Nobody talks about what happens if you don't have calcium. So this was a huge topic. We actually had to do 2 papers. History, none of the journals wanted to accept them, the major journals. I presented this concept at the Northwestern Young Investigator Award. I was told to run away from it. It doesn't have any application. And finally, Jagat Narula and Dr. Fuster thought this would be an interesting aspect to challenge some of the current dogmas, and now they've been cited about 800 times. So, and again, very near and dear to me, my first senior author papers and with my colleagues out there. And what we showed that looking at the whole last 20 years, 85,000 patients, we concluded the absence of atherocalcification puts you at such a low risk that there is absolutely no yield of doing any other diagnostic test, even if you're symptomatic. But more importantly, for the first time, we said, well, you can avoid pharmacotherapy. Now, in 2009, this concept didn't get as much traction, rightly so, because we were at the cusp, we were fighting another battle, that the guidelines were too narrow. So why add another test that's going to narrow it even further? So again, we couldn't find a nail. However, parallel efforts, and we saw the emergence of the Jupiter study in 2008 and 9, and it was trying to really broaden the statin criteria. That would mean almost close to 1/3 to 1/2 of the adult population, a lot of them with LDLs less than 130 and high CRP would be candidates. And actually the Canadian guidelines were really contemplating it, and even there was a lot of discussion about it getting incorporated in the US guidelines. So now this another paper that using that as an incentive and say, well, what about if individuals who meet criteria for Jupiter, they can undergo a calcium testing, and we can really identify, does it work? So the first question was, how many of them would even have a calcium score of 0? You have tremendous amount of inflammation, and we saw the whole details about how inflammation puts you at a higher risk for cardiovascular disease last week. But what we found that almost 1 in 2 individuals who met criteria for that clinical trial in MESA study had a calcium score of 0. Now, who cares about that? What about the events? So what we found that in a 6-year follow-up, which is almost double the time of the entire Jupiter study follow-up, there were hardly any event if you had any calcium score, had a calcium score of 0. So the question is, what is the benefit of a statin therapy in this group? Because you need events to reduce events. And what we found, actually, majority of the events were happening if you had a pretty high calcium score. And that's what the benefit. And even if you assume that the statin would work in this group, you will need to treat almost 550 individuals for the next 5 years to prevent one event. And that's based on loose assumptions. So that was kind of the first hit that we got, and there was a lot of discussion back and forth, and challenges that calcium testing really needs to prove that it reduces events, and my response to that was that actually you don't need to do that if you're trying to prevent individuals from getting therapies. All you need is a prospective data. So other changes that also were happening at that time, I entered into my real-world clinical practice in 2013 as a preventive cardiologist. And I was seeing the entire spectrum. At one end, individuals with tremendous amount of risk factors, significant dyslipidemia, elevated 10-year risk scores, and at the other end, people with almost, you would assume they have no risk. So the question is, for all of us, who would we treat more aggressively? Of course, those with dyslipidemia, those with higher 10-year risk score, with potential hypertension, aging. But as I was getting some of this calcium score, I wasn't too sure, and that was another area of, for me, the uncertainty around here and what trade-offs is. So we went back to the drawing board again and said, well, what happens? How many individuals with the highest risk would actually have a calcium score of 0? So what we found in 2014 in European Heart Journal that yes, if you have a higher risk factor profile, you do get a lesser risk of, or lesser probability that you'll have a calcium score of 0 and higher calcium scores. But still, almost 1/3 of these individuals with the highest number of risk factors would have a calcium score of 0. Now, by early 2000 and 2010, severe dyslipidemia equates to atherosclerosis. In circulation, we showed that actually that's not true. You may have a low HDL, a high triglyceride, and a high LDL, and still about 1 in 2 of those individuals would have a calcium score of 0. But on the other hand, if you had everything normal, almost 42% have early signs of atherosclerosis, and 1 in 5 with someone with a normal HDL and a normal triglyceride and a normal LDL, and that definition keeps on shifting, would have a significant atherosclerosis. Well, it's all about ApoB, LDL particle size, numbers, and we sliced and diced by any ways, and we found the same results. However, who cares if you have a calcium score of 0? What's your risk? Actually, once you take into account your atherosclerosis burden, the value of traditional risk factor really goes out of the window. So you have an individual with a 10-year risk of Framingham of 20% with a calcium score of 0, much lower than somebody with minimal risk and minimal atherosclerosis. And once you have severe atherosclerosis, your risk pretty high, almost CHD equivalent. And the same thing you see with atherosclerosis. It doesn't matter. Now, this concept really caught fire, and a lot of colleagues all across the country got together, and in a series of papers coming over the next 2 years, clearly showed that risk factors and athero, although they go hand in hand, there is huge heterogeneity. At one end of the extreme, individuals at low risk, almost more than 30 to 40% have early signs of disease, and vice versa. So after a lot of deliberation, and then again, trying to figure it out, where are my personal preferences as a physician? In 2014, really, I came to this conclusion that risk factors, be it short-term, lifetime, something that we got started, those 5 risk factors, they are the same wine. You just put them in a different bottle or at a different box and shake it differently and present. In the end, they are extremely imprecise, and it's really time to stop making these wild guesses. And we have an opportunity to start making some more educated guesses. We have tools. We are in 2015. However, that was more at a personal level, but still the guidelines and the physician preferences and the, I would say, the evidence out there was not as supportive. So again, in 2014, coming back with colleagues, and this paper got published in 2015, we started having conversations. And the conversation was, we don't want another paper that shows calcium testing predicts event. We know that. We have a 15-year, 25-year history now. The question what we want to ask is, how does it change practices? How can we invest and trying to investigate what are the guidelines looking for? And to do that, we thought the best way was put ourselves in the stakeholders' shoes and walk that journey in their shoes. So this was our major focus for this paper that was published in JACC in 2015. So the first question we asked is, I'm a patient, I walk into a clinic. I've been told that you need a statin. My 10-year risk is 12%. What's the likelihood that if I choose to utilize a calcium testing, spend $75 to $100 out of my pocket, be exposed to a radiation equivalent to a mammogram, and get an answer in what is the likelihood it will come out to say you have no calcium? Well, we looked at the guidelines in people who were recommended statin, including diabetics and hyperlipidemic. We found a pretty high chance that you will have a calcium score of 0. And even higher if you are in that intermediate where you are asking to be considered statin. Almost 4 to 6 individuals of them would have a calcium score of 0. Okay, that's pretty reassuring. But doc, what about you recommended statin, I got a calcium at 0. Does it really affect my risk? I'm 12%. Actually, it does. Even if you include all the strokes in the elderly individuals, which are likely not atherogenic in nature, an absence of calcium score pushes you way down the threshold where a statin was recommended by our society. So that's great. Now, but at the same time, I was wearing a different hat of population health management. So should I just scan everyone in this room? It's likely going to be an ineffective therapy. None of the systems would agree to that. Can you narrow it down and tell us where exactly it's going to be more effective? So we started looking at the data again in that paper and saying, well, look at the one end, and the green is where the green means you're below the threshold. So if you're low risk, first of all, you're very unlikely to have a calcium score, 1 in 4 chance. And even if you have, it's likely going to keep you there. On the other hand, if you have a very high risk, and yeah, a calcium score of 0 is less likely, and yes, it lowers the risk into half, but it's still not pushing you below the threshold where, as a society, would recommend statin. However, if you focus in the middle group, where this is where the majority and the uncertainty lies, almost 1 in 2 candidates who are designated statins candidate can avoid treatment. So after the study, I thought to put my thoughts in concretely into a more provocative and saying, I think calcium testing, there is no need for screening anymore. Really what we need, this is a decision aid, where the whole idea is you're helping individuals decide whether they need a statin or not. And the highest value is not in those who are not candidates. It's actually people who meet criteria for statin. And the real role is not to identify the highest risk. You can, of course, you can focus, but it's really de-risking uncertain patients. And with this, we truly wanted to open a Pandora box, and we wanted to have more deliberations and discussions across the country. And it didn't take long. Actually, a couple of months after, it's a great video blog by 2 of my heroes, Dr. Libby, Dr. Steve Nissen. I've learned a lot. And however, although I wanted to have the Pandora box open, they wanted to close this Pandora box. And their whole conversation, you should listen. And some of that, I would say a lot of that makes a lot of sense. But I think so that was more the issues that we faced in early 2000. But Dr. Libby provided more of his thoughts in a New York Times article that covered our paper at that time. And he was leery. His rationale was, you get a calcium score, you're going to have somebody gets a high calcium score, Dr. Shah is going to send that patient for an angiogram. Dr. Shah is going to insert a stent. We're going to start them on anti-clotting therapy. They'll notice blood in their stool. We'll stop the therapy. And then eventually they're going to have a fatal heart attack. And this story was so compelling. End of 2015, I feared the first executive order by Trump would be banning calcium to make America safe again. Well, jokes apart, there are facts and alternate facts. So really, does calcium testing have such a dramatic downstream impact? It might have been in the early 2000s where we had no clue, but I wasn't seeing that in my practice or talking to my colleagues. Actually, Dr. Dan Berman did a clear study in LA at that time, randomizing people to statin, a calcium testing, and no calcium testing. And in a 4-year downstream, they didn't see any differences in downstream utilization of CT, catheterization, revascularization, or cost. So you could be truly reassured that the rate of catheterization was only about 3%, whereas high calcium scores you're going to see in 25%. It's not that different than if you you did calcium testing versus not. So pretty reassuring for us. At the same time, when we were promoting this concept, a lot of physicians and some patients also said, well, what about other negative tests? I can check your CRP and homocysteine. Well, you talk about the power of 0. What about the power of other negative tests? IMT, ankle brachial index, again, forcing us to go back to the drawing board, and we compare almost 13 other options in maze and say, well, if only you can use one test, one option, or spend $100, where would you get the highest yield? And then again, it turned out to be the power of 0. So here you can see that across the entire spectrum of pretest risk, the only one information that lowers your risk to a point where you can make a management decision was the calcium score of 0. The next thing came out, well, fine, all great arguments. And, statins are cheap. They're effective, generic. You're just paying $4 to $8. What's the point? Just put everyone on statin. So understanding, and why do you want to add another $100 test up front? So in 2017, we explored this option from a societal perspective, and we found that, even if you assume that some people with calcium 0 would benefit from statin, at the end, it's not going to be as cost effective. So in the end, what happens is, if you're going to use a calcium testing approach to derisk, it's as cost effective as trying to treat everyone. So in the end, we leave it up to the patient and we leave it to the physician. So for example, in my practice and what we advocate, if somebody walks in and we inform them of the options and they still believe that the 10-year risk of 4% is high enough to be treated, I think so they should be on a statin. This test is reserved for those who are uncertain and who would avoid taking treatment if their risk is low. So this was 2017, end of 2000, it was getting close to 2018, and the next one, well, if the data is so good, why there is no endorsement from the guidelines? That's true. We didn't have any endorsement from any guidelines. In the summer of 2018, we heard that the next AHA scientific sessions is going to feature the next new lipid guidelines, and I'm saying, oh my God, we're gonna have the same. I was already scarred, PTSD, and said, well, let me take this option and put my ideas into it and try to get it published. And actually, this paper got published almost a week before the guidelines. And my request, gentle request and nudge to the cholesterol management guidelines, I've done, look, in 2018, it's time that you accept the power of 0. And I'm pushed and nudged for 3 things. The one that was, I thought that the new guidelines, it was critical that they articulate that the primary role of calcium testing in the current environment is to clarify uncertainty around risk estimates. And this is not screening. We have to get out of this mentality of screening. The true value lies in calcium score of 0, not in higher calcium score. And thirdly, now we have enough data that there cannot be a more compelling rationale for it to be at least afforded a class 2A. I understand there is no clinical trial data yet, and it should be a decision aid, not a screening tool. So a week later, the guidelines come, and it was reassuring that they says, well, substantial advancements have been made in the estimation of risk with calcium in the last 5 years. The more pleasing thing was about their acceptance that the most important recent observation has been that the finding of a calcium score of 0 indicate a low CVD risk for the subsequent 10 years. So what happened? They upgraded the guidelines from a 2B to 2A. They went through the same pathway we recommended, 5 to 20%, uncertain patients, use calcium to reduce uncertainty. And for the first time, it says, well, an absence of disease, even in individuals that we are recommending treatment based on our prior guidelines, you can avoid them. I think so that was a big step, and in the next 10 years, when we'll have an ability to look back, we can think this may be the first step where, as a society, as a community, we may be moving away from a risk factors approach to a disease detection approach. And it was really pleasing to see that our paper was a major rationale that was shown at the podium about the absence of calcium score of 0 and 50% in those less than 20% 10-year risk as a rationale for this change. And Dr. Blumenthal, who was one of the guidelines writer and here as a speaker, really put it together. Best tiebreaker if uncertainty. It helps personalization for very low risk group. It's a decision aid, again, not a screening tool, what we called it in 2015. So it will allow you to focus on those who will benefit the most. And another thing happened. This also generated the hashtag power of 0 in 2018 that seems to generate a lot of debate on Twitter even right now. So Dr. Scott Grundy, after that, who was chaired the guidelines committee, and actually he has been chairing these guidelines committees since the early 80s. And he says, well, before starting a statin, talk it over with your doctor and there is a chance, 40% chance that you'll have a calcium score of 0 and your heart attack is very low. That means if you don't do it, unnecessarily a lot of people would be treated. Dr. Zogby met Dr. Fuster this week, and he has a great style, and we asked him a question, and with a very bluntly, he said, well, I have a message for those intermediate risk patients. If your calcium score of 0, forget about the status. Hard to argue with him on this. So now, just trying to wrap it up, and over the last 30 years, I think the first 10 years, there was actually no idea what we're going to do with the calcium testing. The next 10 years was more focusing. We think there is a value of screening that didn't pan out. Actually, I think we have now found a good home as a decision aid. And not only that, so really the value for the stakeholders is that almost 1 in 2 of those statin candidates have no atherosclerosis. They're pretty low risk and truly can allow for informed decision making. And now I think so it's ready for prime time and also guidelines endorsed. And at a personal level, for each of your individual patient level, I think so this is a test that tells you if you don't need a statin. And at a population level, I think so this statin, this calcium test can get millions of people off them. And then again, it's been a long journey, and I just want to take a moment to thank the work of all of these colleagues who I think so, who without that, with their input, we wouldn't have been here. And again, there are many more, but these are the main people I would definitely like to thank. But as I'm just wrapping up for 2 minutes, I want to give you a peek view of where the future is going, because I think the past is great, but this is where we'll be spending most of our time. We still have challenges. And the first is that even today in 2020, in spite of these endorsements, in spite of this data, there is no insurance coverage. The good thing is the prices are pretty down. However, if we truly believe that this is a decision aid, then we cannot have it only for individuals who can afford it. There are tremendous disparities, and we need to work on. And SCCT is making inroads, and advocacy from a lot of the physician community is going to go a lot bigger way. Do we need an RCT? Absolutely, we still do need an RCT, but it cannot be a traditional RCT of just an outcomes. Because if I start treating everyone versus none, of course, in the end, you'll have less events. But are they worth it? What about quality of life, choices, cost, and things? We have to be mindful, and NIH is thinking about those. Severe hypercholesterolemia is another population that we need to think about. What about non-CVD disease? Is it a marker for overall resilience? So the concept of that we need to work around. And now it's not only about statin. I think so we have to start thinking about the novel therapies that are out there. Some of the PCSK9s, purified EPA, GLP-1, SGLT2, it's been reserved for people with established disease. Now we're slowly going to come down into those who are in the primary prevention. So we have to start thinking where the value would be. And also, again, I think we have to make room back again for the power of 0 in the low-risk symptomatic patients. So just as I said, this is a peek. I will give you a sneak into the next series that will come up next year, and hopefully the power of 0 have already started overcoming new hurdles, reclassifying in familial hypercholesterolemia, and we think it's stronger than the soft plaque, and it already has passed another test in very high LDL, but I think in the next year or two, we'll come back with some more advancements, and I hope to get an opportunity to update you then. But even today in 2020, at 7:30 in the morning, I was having a debate with one of my colleagues who wanted to put someone with a calcium score of 0 on a statin. And for her, my message is, in the spirit of shared decision-making, you at least should disclose to the patient that you have a rare condition called good health. Frankly, I'm not really sure how I'm going to treat it. And there's really nothing wrong with you, but I think a little treat will make me feel better. So that's the end. Thank you so much for your attention. Appreciate it.
Khurram, that was a fantastic presentation, and I love the way you took us through the historical perspective. Let me just start off with one question. So I think you provided a compelling case that even if my traditional risk factors suggest that I'm at increased risk and I should be on statin therapy, if I go up to 509, get a coronary calcium and it's 0, then maybe I could withhold therapy for now. The question is for how long? What's the warranty period that you can give me?
That's a question that comes a lot. So, what it tells you, at least for the next 10 years, you're at a low risk. And then again, most of the decisions that we make right now are based on the 10-year risk. So let's look at the traditional risk factors. Your risk's 12% now. You can't lower your age, so your risk is never going to go down. You can lower your LDL, and you may come down and up. What we have found at majority of the individuals will not develop calcification in the next 5 years. So if you look at the SCCT guidelines, the recommendation is to consider that in the next 5 years. Even if you repeat that in the next 5 years, almost exclusively it's going to be a minimal calcification. Now, if you're looking within the spectrum of the guidelines, almost exclusively they think that we should be treating very aggressively if you have a calcium greater than 100. Less than that, it's a shared decision making. So some people may have preferences of being treated more if they have a higher risk, and some may not. So I think that's still going to be a gray zone. Personally, in short, calcium score of 0 today, high risk, no treatment, repeat it in 5 years to have another conversation.
Khurram, that was really beautiful. And you shared with us a history, an amazing history, and your contributions to that history in addition to so many other people, and we're glad you're among us. So that's really great. Question to you, I'm going to be in favor of, we do so much testing on patients. And forget about cardiac. We do CBCs, comprehensive metabolic profile, you name it, many other testing that most of the time are normal. They're costly. They rarely truly change our decision-making. And why not advocate in this to do at least a calcium score on almost all of them? Because what you showed us, right, is that, yes, you may have indications for statin therapy, but for me as an individual patient, if my calcium score is 0, I would feel a little better about my outcome down the line because it is phenotypic to me as opposed to a risk. And if I have some other risk factor that we cannot measure at this stage of the game, and we have a lot of them that we can't measure at this stage of the game, even as my power calculator of risk, which is good, but lacks so much of other factors that would influence my outcome, you've showed us that at times you may have 20% or so that may have a calcium score greater than 0. So actually, I would advocate with these data that you've shared with us today that we are entitled to at least one calcium score at middle age.
I couldn't agree more. What we have learned, again, if you look, the concept of risk factor was first introduced in 1961. 5 risk factors: age, gender, cholesterol, diabetes, hypertension, smoking. 60 years ahead, we are still using just those 6 risk factors. And all we do, as I said, we take them, put it in a box, shake it differently, and present it. I asked the developers of those, what would you have done if you had a calcium score? I said, this was all we had. Why would we even go into risk factors to identify people with atherosclerosis when we have a tool that's going to take 2 to 3 minutes, literally $70 to $100 out of pocket, or even less, with the minimal radiation that you don't need to repeat, that gives you that clarity. And I feel that that's where the future is going to head at some point, where we will have less emphasis on the risk factors. They are great tools to identify targets of treatment, but to whom to treat and identify risk, they do a very imprecise job. And in 2020, moving towards precision medicine, we still cannot have the law of the averages. I agree with you.
Khurram, that was great. I have a question from the mechanistic standpoint. My interpretation is that calcium deposit is a late event in the atherosclerotic disease. So you get your plaque, which is soft, and then as it heals, you get the calcium. So keeping that in mind, is the value of calcium score equal at all ages? If you are 40 or 35 and you have high cholesterol, sure, you're going to be on a statin maybe, but does it have any value to screen you when you may have a higher chances of soft, non-calcified plaque? On the other end, I have had several patients with AFib and avid exercises with low cholesterol, LDL in the 40s, without any treatment, that I do a CT scan pre-AFib ablation, and they're full of calcium. At least two. I've sent them to John and Marianne, and we did nothing. But so I wonder about the sensitivity for the first case scenario and about the specificity in the second case scenario.
So again, if you're talking about, it depends what the question is. Is it coronary artery disease or coronary heart disease? So when you're talking about coronary artery disease, it's 100% specific. For heart disease, we mean complications that may happen due to the disease. So you're absolutely right. There has been a lot of concern. This is a paradox. Individual plaque, more calcium, more stabilized. Higher the calcium score goes up, more events. In 2011, we did a study looking at the entire spectrum of the calcium and the CTA data. So we actually found that if you had a low calcium score, less than 10, most of your plaque was calcified. And the higher the calcium score goes, the more proportion of your plaque were mixed, spotty calcification, non-calcified plaque. That's one. Secondly, age group. So some people would argue that a calcium score of 0 may not have the prognosis in a younger population. And elderly, you're going to see a lot of calcification. What's the point? Actually, that's not true. So we published a paper in Mayo Clinic in 2014 that showed a calcium score. There are actually about 30% of individuals age 70 and above calcium score of 0 doing well. And if they have a higher calcium, greater than 100, they are at the same risk as if you would have the same calcium at age 60, 50, or less than 50. The good thing about atherosclerosis is that it doesn't discriminate based on your age, gender, race, at least in the next 10 years. Now, of course, we need more long-term data to suggest if you had a calcium score of 0 at a younger age, does it still remains prognostically favorable at a 20 years? So we have looked up to 15 years. So far, we are finding the same signal. But the question I have is, we keep on asking more questions for calcium, but none of this happens with a low LDL or a low HDL or any of our ETT. At some point, most of our decisions are going to be within a time frame, because if we are going to talk about lifelong, then the question is, should we start statin at age 20 or 25, where we have to draw some lines? But at least I can reassure you that elderly individuals with higher calcium are at the same risk as somebody as a young, and we need to be very aggressive in therapy.
Khurram, thank you for that. That was a very powerful talk, the power of 0. My question to you, though, is your analysis is entirely premised on the major adverse cardiovascular events, but statins have other benefits. If you have someone with a calcium score of 0, but they have hypercholesterolemia, they may have other benefits with statin treatment, perhaps microvascular dysfunction, which we know occurs in hypercholesterolemia and can lead to vascular dementia, nephropathy, and other disorders. So what is your thinking about the other effects, benefits of statins?
So, I think so. This is an evolving area. You're absolutely right. There is more uncertainty in severe hypercholesterolemia. And I can show you that at least we published a meta-analysis. Even in severe hypercholesterolemic patients, almost 40-some% have a calcium score of 0. And we looked at their outcomes, and we found that at least in the next 5 years, in this high-risk group, there is no event. Now, what you're talking about, other non-CVD, which you and I have discussed a lot, it's interesting phenomena that what we are seeing, if you have a lot of risk factors and a calcium score of 0, in the next 10 to 15 years, we are seeing a lower risk of dementia, lower risk of CKD, cancer, other non-CVD. Whereas if you have high calcium but no risk for these conditions, actually you are going to have a lot of non-CVD. I believe that for reasons people who are vulnerable to developing atherosclerosis in absence of insults are going to have. And if you're protected from atherosclerosis, the likelihood that you will be protected from other events is high, but yet to be seen, definitely an area of uncertainty and for us to investigate more. Yes, please.
Wonderful talk, and to Dr. Zogby's point, as I'm approaching the age of my first colonoscopy, I think a screening calcium score sounds fantastic. My question is, it's very clear in the power of 0 and then the calcium score that's elevated greater than 100. And those that are in the intermediate score, you mentioned shared decision making. Is there any data to support serial calcium score in those patients? And if so, what does that look like in terms of the rate of progression, or are there what markers are you using in addition to that?
The data is not too robust as far as progression is concerned. Yes, it's very simple. Globally, if you have more risk factors, diabetes, smokers, hypertension, severe hypercholesterolemia, you're going to progress more. The rate of progression, there are fast progressors and there are slow progressors. It gets complicated if you start them on a statin. Some of the progression can be also an indication of the statin utilization, but not as fast. From my perspective, the conversation I tend to have with the patients, you already have the disease. I don't know how fast it will be, because for the same people at high risk, it may be a different trajectory. If they are still worse to taking pills, maybe we repeat the calcium testing in the next 2 to 3 years to look at the rate of progression. And if they are rapid progressors, maybe initiate, or just start the statin and forget about it. So yes, again, we have more clarity at the extremes. At 0, absolutely, you don't truly need to do anything. With a calcium greater than 100, I would treat them as somebody with a known CHD. In the 1 to 10, there is a lot of uncertainty. Now, that's where I feel potentially the CTA data can provide some more clarification about the plaque composition and add value. And that's what we have seen in the literature, that the CTA data actually helps a lot in prognostication in that group. George?
Khurram, this was a great, fascinating presentation. Since I am probably the only nephrologist in the room, I just wanted to ask you about the value of the calcium scoring in advanced kidney disease. As we know, they get calcifications, not necessarily in plaque. But I wanted to, probably if the calcium score is 0, of course, that's very, very good. But what is the power of having a high calcium score? What's your advice in this population?
I haven't done much work in this space, but Paula Raji, who was at Emory, has done a lot of work looking at the role. And then again, what we have seen is you see some extra vascular calcification, but not in the coronaries. And individuals with CKD with the highest calcium score tend to be at a high risk. So if you look at the guidelines, if you have CKD, you're already a high risk for the most aggressive therapy. So I would pursue that option and be more aggressive. And if you have a calcium score of 0, which is not that infrequent, you can be more flexible. But absolutely, higher the calcium score, the more risk, more aggressive your treatment needs to be. Yes, sir.
Yeah, microphone down.
That was an excellent presentation. I want to thank you very much. So I'm going to curbside you and tell me what you would do with this. This is interesting. So I have somebody who's got a calcium score of 0 in his early 40s with a strong family history of heart disease, and he got that as part of an executive physical. As part of the executive physical, he also got a carotid ultrasound, and he's got carotid plaque. So on the one hand, he's got a calcium score of 0. We know his 10-year risk is very low. Conversely, he's got a carotid plaque, and he's in his early 40s. What would you do with him?
I would treat him. They have plaque. That's it.
So you would, and you would treat him aggressively.
Yeah.
You try to get his LDL under 70, just like
Absolutely.
everybody else.
Absolutely. You know, in the end, there is room for further clarity in this space. But the thing is, you'll have to do a lot of carotid IMTs and ultrasound to find that one person. But if you found the disease, you have disease in a vascular bed that puts at a risk for cerebrovascular stroke, I would treat them aggressively.
Thank you very much.
Thank you. Outstanding. Nice job.